Madam, we are live now.
I'm Dr. Veena Shinde. I'm a gynecologist and have special interest in high-risk pregnancy. And here we are open for a very nice session on hypertension in pregnancy. Hypertension during pregnancy and delivery management. Classification of hypertension in pregnancy. There is gestational hypertension, preeclampsia, eclampsia, superimposed preeclampsia, and chronic hypertension. Gestational hypertension is a BP of 150 systolic and more than 90 diastolic without proteinuria occurring after 20 weeks of gestation. A transient diagnosis with normalization of BP by 12 weeks postpartum may represent pre-proteinuric phase of preeclampsia or recurrence of chronic hypertension abated in mid-pregnancy. It may evolve to preeclampsia. It is a retrospective diagnosis. A chronic hypertension is a BP of more than 140 systolic and 90 diastolic predating conception. Identified prior to 20 weeks of gestation, it persists for more than 12 weeks postpartum. Use of antihypertensive medications before pregnancy is known. Preeclampsia occurs after 20 weeks of pregnancy. The BP is more than 140 systolic and 90 diastolic. Proteinuria of 0.3 grams protein or higher in a 24-hour urine specimen or more than +1 per dipstick. In the absence of proteinuria, new onset hypertension with the new onset of any of the following: thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. Eclampsia is the presence of new onset grand mal seizures in a pregnant woman with preeclampsia. New onset seizures 48 to 72 hours postpartum. Other central nervous system pathology is the likely reason for the seizure after 7 days. Rule out idiopathic seizure disorder or other central nervous system pathology such as intracranial hemorrhage, bleeding, arteriovenous malformation, and ruptured aneurysm. Classification of hypertension in pregnancy: superimposed preeclampsia, new onset in a woman with hypertension prior to 20 weeks, sudden increase in proteinuria if already present in early gestation, sudden increase in BP, development of HELP syndrome, development of headaches, scotomata, or epigastric pain. Hypertension in pregnancy, fast figures. Hypertension disorder are common and complicate obstetric practice in India. Incidence of preeclampsia in hospital practice in India varies from 5 to 15%. Incidence of eclampsia is about 1.5%. The etiopathogenesis: stage 1, first and second trimester, immunological, genetic factors, environmental factors, placental dysfunction may cause intrauterine growth retardation. In the second and third trimester, hypertension, proteinuria, maternal syndrome, eclampsia, or HELP syndrome. The clinical risk factors for preeclampsia: primiparity, previous preeclamptic pregnancy, chronic hypertension, renal disease, history of thrombophilia, multifetal pregnancy, in vitro fertilization, family history of preeclampsia, diabetes mellitus, obesity, SLE, and advanced age above 40 years. Severity of preeclampsia: preeclampsia with the absence of severe manifestations often has been characterized as mild. It should be noted that this characterization can be misleading. Even the absence of severe disease, morbidity and mortality are significantly increased. Therefore, the term preeclampsia without severe features may be used instead. Severe features of preeclampsia: any of these findings: a systolic BP more than or equal to 160, a diastolic BP of more than or equal to 110 on 2 occasions at least 4 hours apart while the patient is on bed rest, unless antihypertensive therapy is initiated before this time. Thrombocytopenia, a platelet count of less than 1 lakh per microliter. impaired liver function as indicated by abnormally elevated blood concentrations of liver enzymes to twice normal concentration, severe persistent right upper quadrant or epigastric pain, unresponsive to medication and not accounted for by alternative diagnosis or both. Progressive renal insufficiency, serum creatinine concentration of more than 1.1 milligram per deciliter, or a doubling of the serum creatinine concentration in the absence of renal disease. Pulmonary edema, new onset cerebral or visual disturbances. Complications of preeclampsia, cardiorespiratory, ARDS, pulmonary edema, cardiomyopathy, generalized edema, neurological eclampsia, cerebral hemorrhage, altered mental status, renal, acute tubular necrosis, acute kidney injury, glomerular endotheliosis, hepatic periportal inflammation, hepatic dysfunction, hepatic hematoma, acute fatty liver of pregnancy, hematological thrombocytopenia, DIC, microangiopathic hemolysis, venous thromboembolism. First trimester risk assessment for early onset preeclampsia. The American College of Obstetricians and Gynecologists Committee opinion. Best and only recommended screening approach for preeclampsia is taking a detailed medical history to evaluate for risk factors is currently the best and only recommended screening approach for preeclampsia. It should remain the method of screening for preeclampsia until studies show that aspirin or other interventions reduce the incidence of preeclampsia for women at high risk based on first trimester predictive tests. Current predictive tests for preeclampsia may harm more women than they benefit because of their low positive predictive value. Management of preeclampsia, to maintain a safe blood pressure, to monitor the mother for deteriorating disease, to monitor the fetus for signs of placental dysfunction and growth retardation. Prevention of preeclampsia recommendation, women with medical history of early onset preeclampsia, preterm delivery at less than 34 weeks of gestation, preeclampsia in more than one prior pregnancy, initiating the administration of daily low dose 60 to 80 milligram aspirin beginning in the late first trimester is suggested. Meta-analysis of more than 30,000 women in randomized trials of aspirin indicates small reduction in incidence and morbidity of preeclampsia and reveals no evidence of acute risk, although long-term fetal effects cannot be excluded. Prevention of preeclampsia, administration of vitamin C or vitamin E, dietary salt restriction, bed rest or restriction of physical activity is not recommended. Management, gestational hypertension, systolic BP of less than 160 and diastolic BP of less than 110 or preeclampsia without severe features. Initial evaluation, CBC with platelet count, serum creatinine, liver function test, urine protein, 24-hour collection of protein creatinine ratio, symptoms of severe preeclampsia, fetal evaluation, sonography for fetal weight, amniotic fluid index, non-stress test, biophysical profile if NST is non-reactive. Antepartum management, continued evaluation of fetus and the mother. For the fetus, kick count daily, USG every 3 weeks, amniotic fluid volume once a week, NST weekly or twice weekly. Mother's evaluation, blood pressure at every visit, evaluate proteinuria, laboratory CBC, liver enzymes, serum creatine once a week. Advice to patients in the antepartum management, women are instructed to report symptoms of severe preeclampsia, that is headache, visual changes, epigastric pain, shortness of breath. They are advised to immediately come to the hospital if they develop persistent symptoms like abdominal pain, contractions, vaginal spotting, rupture of membranes, or decreased fetal movements. Antihypertensive therapy, the Cochrane review, no consensus regarding the management of non-severe hypertension. Therapy may decrease progression to severe hypertension, but also may be associated with impairment of fetal growth. A recent systematic review of 46 trials evaluated BP control in women with mild to moderate hypertension. The authors concluded that it is unclear whether antihypertensive therapy is worthwhile. When to initiate antihypertensive therapy? NICE, that is the National Institute of Health and Care Excellence, recommends commencing therapy when blood pressure exceeds 150 by 100. Recommends treatment only for blood pressure over 160 by 110. WHO guidelines specified that the evidence is not yet sufficient to determine which strategy is preferable, but ongoing studies will clarify this issue in the near future. Avoid reducing the blood pressure below the lower limits, that is below 110/80, which would lead to a risk of placental underperfusion. Antepartum management, bed rest. The Cochrane review of 4 randomized trials that compared bed rest with no rest in pregnant women with mild hypertension found insufficient evidence to provide guidance for clinical practice. Bed rest should not be prescribed. Intrapartum management, timing of delivery, less than 37 weeks of gestation, expectant management with maternal and fetal monitoring is suggested. Beyond 37 weeks, delivery rather than continued observation is suggested. Intrapartum management, hospitalization and delivery for one of or more of the following reasons: that the patient is more than or equal to 37 weeks of gestation, there is a suspected abruptio placenta. If the patient is 34 weeks or more, plus any of the following, that is progressive labor or rupture of membranes, ultrasonographic estimation of fetal weight less than the 5th percentile, oligohydramnios persistent, that is amniotic fluid index less than 5 centimeters, persistent BP 6/10 or less. Universal use of magnesium sulfate therapy in preeclampsia without severe features is not recommended. Certain signs and symptoms have traditionally been considered as premonitory to seizures and should be considered in the choice of initiation of magnesium sulfate therapy. Clinical course of women with preeclampsia without severe features can suddenly change during labor. All women with preeclampsia without severe features who are in labor must be monitored closely for early detection of progression to severe disease. Magnesium sulfate therapy should then be initiated if there is progression to severe disease. Maternal and fetal findings at 37 weeks or more of gestation or 34 weeks or more of gestation with labor or rupture of membranes, abnormal maternal fetal test results, ultrasonographic estimate of fetal weight less than 5th percentile, or if there is a suspected abruptio placenta, delivery, prostaglandins if needed for induction. If it is less than 37 weeks of gestation, inpatient or outpatient management, maternal evaluation twice weekly, fetal evaluation with preeclampsia twice weekly, NST with gestational hypertension, weekly NST, 37 weeks or more of gestation, worsening maternal or fetal condition, labor or premature rupture of membranes, then you should deliver the patient. Treatment of severe disease, severe hypertension or severe preeclampsia. Severe hypertension, it can be a feature of essential or gestational hypertension, but may also represent progression to full preeclampsia. The objective of treating severe hypertension are prevent potential cardiovascular, renal, or cerebrovascular complications related to uncontrolled severe hypertension. Patients should undergo a full evaluation, including urine, blood tests, to detect new onset of preeclampsia. The target of treatment should be to maintain BP at less than 150/100. Blood pressure should be checked at least every 5 minutes while attempting to gain control, and if refractory, consideration should be given to invasive monitoring. Severe hypertension, updated Cochrane systematic review of 35 trials that involved 3,573 women found no significant differences regarding either efficacy or safety between hydralazine and labetalol or between hydralazine and any calcium channel blocker. Theoretical concern exists that the combined use of nifedipine and magnesium sulfate can result in excessive hypotension and neuromuscular blockade. Choice and route of administration of drugs should be primarily based on the physician's familiarity and experience, adverse effects and contraindications to the prescribed drug, local availability, and cost. Acute onset severe hypertension during pregnancy and postpartum period. Intravenous labetalol and hydralazine have been considered as the first-line medication for the management of acute onset severe hypertension in pregnant women and women in a postpartum period. Immediate release oral nifedipine also may be considered as a first-line therapy, particularly when IV access is not available. Other drugs does not require cardiac monitoring. Emergent consultation with an anesthesiologist, maternal fetal medicine subspecialist, or critical intervention is recommended if above drugs fail to relieve acute onset severe hypertension. Mechanism: atenolol, captopril, enalapril, should be avoided. That is, beta blockers, ACE inhibitors should be avoided and are associated with severe fetal anomalies, fetal growth retardation, bradycardia. So these drugs are to be avoided: atenolol, captopril, enalapril during pregnancy and breastfeeding. They can be given postnatally after breastfeeding is over. The drugs which we generally give are labetalol, methyldopa, hydralazine, and nifedipine. Labetalol is a beta blocker. It can be given intravenous for rapid control of severe resistant hypertension. It is recommended during breastfeeding. Very small amounts in the breast milk, no evidence of harm. In the postnatal period also it can be given. The side effects are tachycardia. It is contraindicated in asthmatics. Methyl-dopa, it's alpha-2 agonist, included in first trimester, longest post-marketing surveillance data. There are no evidence of any harm during breastfeeding. In postnatal period, it is avoided. It may cause depression, reduced variability on CTG, methyl-dopa hepatitis is known to occur. It is contraindicated in mental health disorders and hepatic disease. Hydralazine is a vasodilator. It is used intravenous for first rapid blood pressure control, may be associated with neonatal thrombocytopenia, long history of use. Avoid rapid IV bolus because of risk of hypertension. Excreted in breast milk at levels too low to be harmful, and it can be used in the postnatal period. Nifedipine is a calcium channel blocker. After 20 weeks, it is available in short-acting forms for rapid blood pressure control and long-acting form for long-term maintenance therapy, may be used simultaneously with magnesium sulfate and may inhibit labor. Manufacturers advise avoid to be used during breastfeeding. Amounts in breast milk are too small to be harmful. In postnatal period, it is generally not used. The side effects are headache. Severe preeclampsia, maternal and fetal monitoring during expectant management. Maternal assessment, vital signs, fluid intake, urine output should be monitored at least every 8 hours. Symptoms of severe preeclampsia should be monitored. Presence of contractions, rupture of membranes, abdominal plane, bleeding should be monitored. Laboratory testing should be performed. In the fetal monitoring, kick count, NST with uterine contraction monitored daily, biophysical profile twice weekly. Serial fetal growth should be performed every 2 weeks. Umbilical artery Doppler study should be performed every 2 weeks. Fetal growth restriction should be seen. Severe preeclampsia, corticosteroids for fetal lung maturity. Antenatal corticosteroids for accelerating fetal lung maturation for women at risk of preterm birth. Women with severe preeclampsia receiving expectant management at 34 weeks or less of gestation, corticosteroid treatment results in less frequent respiratory disease, neonatal death, and intraventricular hemorrhage. Do women with preeclampsia and their babies benefit from magnesium sulfate? The MACPI trial, a randomized placebo-controlled trial, 50 to 67% reduction in risk of seizures, reduction in risk of maternal death, may have some benefit to the baby. A 4-gram loading dose with a maintenance infusion of 1 gram per hour, monitoring observation of urine output, respiratory rate, and deep tendon reflexes. The timing of delivery, less than 34 weeks of gestation, stable maternal fetal conditions, continue the pregnancy only at facilities with adequate maternal and neonatal intensive care resources. More than 34 weeks of gestation, unstable maternal fetal conditions, delivery as soon as stabilization of maternal condition is recommended. Delivery decisions should not be based on amount of proteinuria or change in the amount of proteinuria. Delivery once maternal is stable. Observe and delivery for first 24 to 48 hours, corticosteroids, magnesium sulfate prophylaxis, antihypertensive medications, ultrasonography monitoring of fetal heart rate and laboratory test. Contraindications to continued expectant management: eclampsia, pulmonary edema, disseminated intravascular coagulopathy, uncontrollable severe hypertension, non-viable fetus, abnormal fetal test results, abruptio placenta, intrapartum fetal demise. Additional expectant complications at more than 33 weeks of gestation, persistent symptoms of HELP, severe oligohydramnios, reverse diastolic flow, labor or premature rupture of membranes, Expectant management should be done in facilities with adequate maternal neonatal intensive care resources, fetal viability at 33 weeks of gestation, inpatient only, and stop magnesium sulfate daily maternal fetal tests, vital signs, symptoms, blood test, oral antihypertensive drugs, achievement of 34 weeks of gestation, new onset contraindications to expectant management, abnormal maternal fetal test results, labor or premature rupture of membranes, conduct the delivery. Eclampsia, occurrence of generalized tonic-clonic convulsions or coma in women with preeclampsia, which cannot be attributed to other causes. There is a maternal mortality of 4 to 6%, perinatal loss of 45%. Incidence may be 1 to 55 of all pregnancies in India. Eclampsia, the most common in the last trimester, becomes increasingly more frequent as term approaches and may occur up to more than 48 hours postpartum. High fever in eclampsia is a very grave sign which may be a consequence of central nervous system hemorrhage. Major complications are placental abruption 10%, neurological deficit 7%, aspiration pneumonia 7%, pulmonary edema 5%, cardiopulmonary arrest 4%, acute renal failure 4%, and maternal death 1%. Management: stabilize the mother through application of a standardized ABCDE, airway, breathing, circulation, disability, and evaluate approach. If eclamptic seizure not terminated by itself, magnesium sulfate should be commenced as soon as possible. Further bolus of magnesium sulfate may be given and the maintenance infusion may be increased to 2 grams per hour. Hypertension should be controlled as discussed previously. Recurrent seizures may warrant intubation, paralysis in order to maintain oxygenation. Fetal bradycardia may be seen in cardiotocography, but seizure and BP control is the primary intervention. As soon as mother's condition is stable, she should be delivered by most expedient route, may be achievable vaginally, but will most commonly be a cesarean section. Effects of increasing plasma levels of magnesium sulfate therapy. 4 to 7 milliequivalent per liter is a therapeutic level. 10 milliequivalent per liter, patellar reflexes disappear, impending signs of magnesium toxicity. More than 10 milliequivalents, respiratory depression, and 12 milliequivalents, severe respiratory depression treated with prompt intubation and mechanical ventilation. The HELP syndrome. Severe preeclampsia complicated by hemolysis, elevated liver enzymes, and low platelets. Occurs in 12% of pregnancies complicated by preeclampsia or eclampsia. Laboratory findings of hemolysis, abnormal peripheral smear, total bilirubin of more than 1.2, LDH more than 600, raised liver enzymes like AST, SGOT more than 70, platelet count of less than 1 lakh. Stabilize the mother, control the BP, prevent the seizures, evaluate fetus for well-being, determine optimal timing and route of delivery as soon as possible, provide continuous monitoring and management during postpartum period, and all parturients should receive magnesium sulfate. Dexamethasone 10 milligram IV 12 hourly when platelets are less than 1 lakh, platelets for active bleeding, or if less than 20,000, plasmapheresis has limited success. Anesthetic implications, careful pre-anesthetic assessment if is required for airway edema and compromise, aspiration prophylaxis, auscultation of lungs for pulmonary edema, fluid balance with correction of hemoconcentration, hemodynamic status, left uterine displacement causing uterine vascular hypotension, renal function, and coagulation status. Anesthetic for labor, analgesia of labor should be provided with replacement of continuous lumbar epidural catheter. Advantages are decreased circulating catecholamines, less uterine vascular resistance, and improved uteroplacental blood flow. May also avoid the risk of general anesthesia. Anesthesia for delivery, non-emergent cesarean section, epidural anesthesia or spinal anesthesia. Emergent cesarean section, epidural if previously placed and well functional, spinal if no epidural placed and fetal heart rate are stable, general if there is a coagulopathy, patient's refusal and fetal bradycardia. Anesthetic management of eclampsia by immediately instituting aspiration precautions, careful airway assessment, selection of a technique, region anesthesia in high blood pressure given when platelet counts are 80 to 1 lakh, airway breathing, circulation and control of BP with drugs is required. Neuraxial anesthetic techniques, preferable to GA for elective cesarean in absence of HELP syndrome, reduces serum catecholamine levels, improves uteroplacental blood flow, improves intervillous blood flow in preeclamptic parturience by decreasing uteroplacental resistance associated with that Apgar 1 and 5-minute compared to systemic opioids. In absence of contraindications like HELP syndrome, coagulopathy, and thromboelastography, neuraxial anesthesia is preferred for cesarean birth in preeclampsia, and lumbar neuraxial anesthesia is appropriate in preeclampsia during labor. Future health risk and screening. Future risk: when women who have had hypertensive complications in pregnancy receive postnatal counseling regarding the management of future pregnancy. Women with gestational hypertension, the risk of recurrence of hypertension in the next pregnancy is 16 to 47%, and of preeclampsia is 2 to 7%. Women with preeclampsia, risk of recurrence is 16% if delivered at term, and 25% if they delivered at 34 weeks, and 55% if they delivered less than 28 weeks. They are advised to book early in their next pregnancy. Consideration of starting low-dose aspirin as a prophylaxis. Women on long-term antihypertensive therapy should be counseled to stabilize blood pressure before conceiving. Should have more frequent BP and urine dipstick monitoring. Delivered less than 34 weeks should be screened for antiphospholipid antibody syndrome. Future risks and screening. Associated adverse outcomes demonstrated by a meta-analysis: increased risk of cardiovascular disease, chronic hypertension, venous thromboembolism, cerebrovascular disease. Simple lifestyle modifications suggested by obstetric team and primary care physician to help reduce future risks are weight loss, smoking cessation, low salt, and regular exercise. Thank you.
Hello.
Yes.
Yes, madam. You can stop sharing your screen now.
Okay.
Yeah. Now we also have some questions. I will just post one by one questions in the chat section.
How strongly are cell-free fetal DNA correlated to preeclampsia? How strongly are cell-free fetal DNA? They are seen to be correlated to preeclampsia. Is there any relationship between vitamin D deficiency? Yes, there is a relationship between vitamin D deficiency and preeclampsia. If vitamin D is corrected, hypertension gets controlled. There is a very strong relationship. Which markers of endothelial cell injury are elevated in women who develop preeclampsia?
Hello.
Hello?
Yes, madam. You need to answer the third question.
Yes, I will answer it.
Yeah.
Nitric oxide levels can be checked. Which hemolysis related results suggest clotting factors, low platelet count, PT-CT, PT. In women with new onset hypertension without proteinuria, what additional symptoms are needed? Headache, visual disturbances.
Hello.
Hello, headache, visual disturbances.
Yes, madam. We have completed with all the questions. Yeah, and thank you very much for giving your valuable time and sharing important insights on the topic in a very beautiful and executed manner.
Thank you.
Yeah, thank you, madam. You can close now.